Hey there, and welcome to the Knee Gurus, your guide to understanding knee injuries and recovery. I'm Bevan Collis, physiotherapist and founder of Asia Physio. With our clinics in Japan and Singapore, we help people get back to doing what they love. Each episode, we dive into real stories and expert conversations about life after a knee injury, from surgeons and physios to patients who've been through it all. So whether you're fresh off an injury or just curious about your options, you're in the right place. Let's get started.
Hi guys, and welcome back to the Knee Gurus podcast. I'm your host, Bevan Collis. I'm super excited to present this show to you today because I've been trying to get Dr. Tom Cross on our podcast for quite a long time, and he finally relented. Tom Cross is a bit of a legend in Australian sports medicine and global ACL management now. He's the son of Dr. Merv Cross, who is Australia's most iconic orthopedic surgeon, one of the first surgeons to do ACL reconstructions in Australia and bring in specialisation into surgery. One of Australia's first knee specialists. And together they founded the cross bracing protocol, which many of you may have heard of, which is a unique and novel approach to maximising the chance of ACL healing. In today's episode, we're diving deep into the world of ACL injuries in skiers, a topic that's really been at the center of my clinical work for many years. And alongside Tom is Ryan Kerr, who's a physiotherapist with more than a decade of experience working in ski resorts and helping injured skiers get back on the slopes. So we discuss ACL injuries in skiing, rehabilitation strategies, return to sport, how to prevent an ACL on your ski holidays, and what things you might want to consider doing to get home safely if you are unfortunate enough to suffer an ACL on a ski trip. So I really hope you enjoyed this conversation as much as I did. Let's get into it. So Tom and Ryan, it's great to have you both on the show.
Thanks very much, Bevan. Thanks for having us.
Cheers.
Yeah, thanks for having us, Bevan.
Thanks, Ryan. Ryan, can you tell us a little bit about your journey in the ski industry? You've got a really interesting background and story to tell.
Yeah, for sure. So I started physiotherapy in netball, actually working down in Melbourne for Netball Victoria when I first started my career, and then quickly moved into the ski industry with a parallel career as a ski instructor. And so I worked through the ski instructor pathway at the same time as working around Jindabyne, one of the local clinics there. And then during COVID, when everything was kind of going a bit crazy and moving online, I started to get into a little bit of like online coaching and online physiotherapy and working with some snow sports athletes who are in various parts of the world and stuck in various parts of the world. So kind of dived into the online rehab space and being able to manage athletes remotely from a physiotherapy standpoint, which seems a little bit unusual because most people, when they think of physio, think about, massage and lots of touchy-feely, all that sort of stuff. But I found with elite athletes, they're also switched on with what they're doing in the gym and with their sports anyway, that with some good guidance and lots of videos and lots of interactions over text message and video, you can actually rehab people fairly well, especially in the later stages, doing that remotely. So I sort of went down that path a little bit at the same time as continuing with the in-person work in Jindabyne. And then on the ski instructing or ski coaching world, I now work mainly for the APSI, which is the Australian Professional Snow Sports Instructors, and they're the body that certify and examine and train ski instructors within Australia. And I work between Australia and Verbier in Switzerland, training ski instructors around the world at the same time as, managing and doing some strength and conditioning and physiotherapy for some of our Aussie athletes, training all over the world. That's where I am now.
Awesome. What a great story. It was just, as we were saying before, the ski industry, some people just stay in it for 3 months, but there's other people who really fall hard for it and go into a lifelong journey with the sort of seasonal nature of it. And what a super fun life it is, I think. And Tom, can you tell us a little bit about your background and maybe a brief history of the cross bracing protocol? I know it's a very long story, so we won't go to the full history of it, but if you can tell us a little bit about how it began, just for people who might not have heard of it before.
Sure thing, Bevan. So I'm a sport and exercise medicine physician in Sydney, Australia, and I've been a doctor 32 years and involved in sports medicine for 29 of them. In the last 7 years, I've specialised or done a deep dive into this research into the potential for some ACLs to be facilitated in their healing, and to how to recognise the ones that may have that healing potential. I wouldn't be talking to you today unless my father, Merv Cross, so I'm biased, but he was a very significant knee surgeon here in Australia for many decades. And in 2014, he had this epiphany, and no one knows why he didn't have the breakthrough in thinking years before that. But he was a 73-year-old retired knee surgeon in our clinic at the stadium in Moore Park. There was a 19-year-old girl that had a ruptured ACL. She was the daughter of one of our staff, and I was consulting her in the physiotherapy area, and I'd known her for 5 years, and I knew her mother well. She was one of our reception team, and I diagnosed her ACL rupture, saw it on MRI, and was getting her ready for surgery. And unlike a lot of young people, she had experience with two other athletes that had ruptured their ACL and unfortunately didn't do well with surgery and really ruptured quite quickly, returning to netball. And my father stepped into the consultation when Emma said, "I don't want surgery," and said, "Bend the knee and we might be able to facilitate the healing and approximate the ruptured ligamentous tissues." And so that was patient number one, and it worked for Emma. And that led to this journey of, it took 5 years to get 5 more patients, and they were friends, family. One of them was my nephew, who was patient 3. And then patient 6 came along in 2019, who didn't know my father and I. And he was a very talented rugby union and rugby league player. He had the Waratahs in Australia were interested in him. The Sydney Roosters were interested in this young boy. And he came in with a ruptured ACL, and I said, "Toby, I think you need surgery." And he also had a jaundiced view of surgery, unfortunately, where his brother and mum had surgery that didn't, unfortunately, re-ruptured. Mum had re-ruptured twice. So he said, "Is there another way? Have you got anything else you can offer me other than surgery?" And I said, "Well, there's this crazy idea of bending the knee, which 5 people have done." And I explained the principles to him and his father, and they said, "Well, why wouldn't we try it?" And we did the maths that we could get him back, if it didn't work, to rugby league and rugby union the next season. So when Toby healed, it was quite extraordinary, because he had a 6 millimeter gap that was completely ruptured. Back then I was doing a Lockman in the clinic. I don't do them now when they come in. I could explain that later. And then I felt the crisp endpoint, 12 weeks later, and saw the MRI. And that was a very, very big turning point for me, because then I decided to devote myself to this research and find out why it worked, who it may work well on. So I had to retire from the Swans as their doctor the following season, retire from going to the hospital and assisting surgeons. And I just have spent the last 6 years in the clinic doing this deep dive into ACL injury and investigating the types of tears that are amenable to this treatment and the ones that are not. And we can talk about that today.
And
so I didn't call it the cross bracing protocol. The physios named it that after patient 450. We just called it the bracing protocol, or bending the knee, to do a closed reduction of the ACL. So that's the story. We're now up to so patient 1,426 adopted the treatment this morning in Sydney. We've learned a lot, particularly in the last 6 years. We're collaborating with the University of Melbourne, University of Sydney, and many people around the world. So it's exciting. The two things that you have to be careful with a novel treatment is it effective and is it safe for the patients? And at the moment, the efficacy and the safety profile are very compelling, in that it is effective if you do it properly, and it is safe if you do it properly. But we can talk more about how you prescribe it, how you make it effective, and how you make it safe. Because if it's done poorly, it can be very ineffective and very unsafe. So it's like any medical treatment. But it's exciting because we're seeing patients with ruptured ACLs that, with the greatest respect, every surgeon on the planet would operate on, and we're getting good healing. And so far, a significant number are not re-rupturing, and they're very happy. So, but I'll say up front, we need more science, and we're gathering it. We're being very careful and scientific, and there are a lot of knowledge gaps, but we're hoping to fill them in the years ahead, collaborating with these universities and publishing scientific papers. But it's very exciting because a lot of people want to try something non-surgical before they get surgery. And for a lot of knee-injured patients, the operation is not an emergency. For some people it is because they're a high-level athlete, and they want to get back to sport as soon as possible without any doubt. But for the vast majority of ACLs, that there is not an urgency, and they can afford to try a non-surgical treatment. So hopefully that explains the background.
Yeah, what a great story. And I don't think it's hyperbole to call your father, Merv, probably the most famous and even most iconic knee surgeon in Australia. He was certainly, when I was graduating from physio, he was very well known as one of the top, if not the top, knee surgeon in the country. So it's it just adds that extra layer of interest to the whole story about your family background and how Merv spent his career doing surgeries, and then sort of at his towards the end of his career and life, I guess, left us with this great gift of understanding more about how the ACL can heal, which is just perfect story. And you mentioned
Funnily enough, both of my parents have had their knees operated on by Merv.
Oh, really?
Yeah.
My wife's dad had his operation done by Merv as well.
And if you're from the Sydney area, I'm sure everyone knows someone that's had Merv operate on them.
Yes. And Tom,
he touched a lot of lives. So he was prolific.
You mentioned a couple of
people say, why didn't he have this epiphany earlier, while he was operating? Sometimes it takes a whole career to have some sort of breakthrough like this. And also he was in a clinic, and I was his son, and he had all these resources to enable the research into this idea. I'll probably say up front, when we say ACL healing, that's a very broad term, and there's a big range of healing or spectrum, from quite very anatomical restoration of the ACL and healing to a spectrum of non-anatomical healing. And in the healing zone, there is scar tissue. So the ACL has come together, and there's a degree of fibrosis and disorganized collagen. And it's up to the patient and the physical therapist to try to maximize the strength of that construct and the collagen alignment and remodeling, and minimize the scar tissue and disorganization of collagen. And that's a knowledge gap, and we're watching the re-rupture rate like a hawk, and following up the patients meticulously. The only tissue in the body that fully heals without scar tissue is bone and liver when it's injured. So, skin, muscle, tendon, ligament, nerves, when they get injured, and we approximate the tissues and heal them, there is a degree of fibrosis and scar tissue in there. So we all need to be cognizant of that, and that what we heal can't ever be as strong as nature. What's in a normal ACL, say in their contralateral knee, if they've never been injured. So I always tell that to the patient, their family, that we can't give them nature, but if you get an anatomical restoration where you've got high volume, good thickness, good alignment, and then 12 months later the MRI has homogeneous, dark, low signal, you've got something pretty close to nature. And the only way to know how strong it is to follow the patients up and look at the re-rupture rate.
And how does that compare to surgery, Tom, to
Well,
the reconstruction?
so that's when you say surgery, that's also a broad term because
Mm,
every surgeon will have a different re-rupture rate and, with the greatest respect, skill in doing an ACL reconstruction. So if you pull all the surgeons together and all the different types of grafts performed, and is it a hamstring, patella, quad tendon? Is it an allograft, et cetera, et cetera? What's the tunnel positioning like? Have they added a lateral reinforcement procedure? You've got all these different heterogeneous groups of surgery, and they'll all have a different re-rupture rate. And that's where the ACL registries are so important to delineate the re-rupture rate of each particular graft, each particular operation, and also, with the greatest respect, each surgeon will have a different re-rupture rate. So one of the tasks of the research is to look at the re-rupture rate of CBP and all the different healing outcomes, whether you go back to the same level of sport or a high level of sport, or you retire from ACL demanding sport. So there's a lot of work to be done, and hopefully we have some really good statistics for the patients who rupture their ACLs in the future. And we can say, well, you've got this tear type. These are your options in non-surgical. You can do these various types of bracing protocols with varying degrees of challenge, or you could go and get this type of surgery and with this re-rupture rate, this profile of complications and morbidity. So the patient's got a lot more information and has the degree of understanding and informed consent. So, and patients like that these days, whether they're seeing a sports medicine doctor, surgeon, or they're seeing any type of doctor, they'd like to know all their options. And in medicine, you've often got non-surgical, surgical, and what each option looks like. And it also has to be bespoke for that particular patient. Well, who is that patient? And what is their pathology? So you tailor the treatment for that particular patient. And that's very much the case with ACL.
And is there any early
I hope that
signs
makes
on
sense.
Yep.
Yeah.
Any early signs on the re-rupture rates of cross-bracing protocol compared with surgery? Still too
Well,
early to get meaningful data.
it's probably a bit early. My phone kept ringing with people re-rupturing. I would say openly that the CBP is only for people who want to give up sport or give up ACL demanding sport, such as skiing, soccer, touch footy, OzTag, netball, basketball, rugby league, rugby union, AFL, ultimate frisbee, jiu-jitsu, motorbikes, all these things that involve pivoting, jumping and landing, putting your foot down at speed. So, but it's not, my phone's not ringing with a very high re-rupture rate. At the moment, your re-rupture rate depends on whether you get an ACL OAS score of 0, 1, or 2. So for people that aren't aware of that validated ACL healing classification, so an ACL OAS score of 0 means you show an MSK radiologist the healed ACL, and they say that's a normal ACL. Why are you showing me that MRI? So that's a 0. A 1 is got excellent volume, good alignment, but might be a little bit thick, and it might be a little bit heterogeneous, the signal in the ACL. That's a 1. Then a 2 is a thinned and or elongated ACL. So it's got less volume, or it's lax and sort of draping through the knee. And that's a very big category because you can have very thin, very elongated, or you could have normal thickness, just elongated. So there's a spectrum of healing. And if you think about it in terms of newtons of force capacity, there's a spectrum of force that healed ACL will absorb before it breaks. So at the moment, our zeros have a 5% re-rupture rate, and our ones are 10%, and the two is 15. So, like I said, we're really following the patients up. We have 1,426, 1,000 are more than 1 year, up to 12 years. But we really need to follow them up for 5 to 10 years to really look at the re-rupture rate. We need to follow them up for 20 years to look at the incidence of osteoarthritis and compare that to surgery. So there's the CBP is not in its infancy anymore, but it's sort of in its adolescence. It's where we're continuing to pursue it and try to answer the knowledge gaps. One of them being re-rupture rate, successful return to sport. The only way you can do that is to do meticulous science, and which is hopefully what we're doing.
Yep, yep. And I have seen the figure of around 27% re-rupture rate around surgery quoted. Did you have any
I think that's a bit high. I think because the top surgeons in Sydney that I work with can get it down as low as 5 to 10%. So that could be pooling all the surgeons together. The surgeons in some remote places might be doing 15 ACE a year, so that they get pulled into the elite surgeons who do 200 or 300 a year. So it all depends on the surgeon, the re-rupture rate. That's why the patient needs to take control and get referred to an excellent surgeon, and get a lot of opinions, talk to people, talk to doctors, physios. And like I said, it's usually not a rush for most people. If you've got a significant meniscal injury, like you've got a locked knee, bucket handle tear, there's more urgency to get the surgery. But not many ACLs have that.
Yeah. And you mentioned about the ACL OAS, which is a classification that's widely accepted for healing. But on the other end of the spectrum, where we probably haven't had enough science, enough interest around classifying, is classifying the actual types of ACL tears. And I know probably you'd agree with this, Ryan. When we studied, we were sort of taught that the ACL tear is binary. You've either, it's a yes or no. You've done your ACL or you haven't done your ACL. We used to joke doing your ACL was like being pregnant. You've either done it or you haven't done it. You can't half do it. But we now know that's incorrect. And as I understand, Tom, you've recently published a paper on what's really, I think, critical for the future of ACL management is this tear type classification and our understanding of all the different types of ways that an ACL can tear and how those tear types match up with healing potential, and then matching those two up and bringing in all the other factors around the patients, who they are, what their goals are, into that decision-making process, particularly in those first couple of weeks post-injury where we're really seeing them in the ski resorts. Can you tell us a little bit more about the ACL tear type classification, Tom?
Yeah, of course. So back in 2019, when Toby healed, the patient number 6, and I started in earnest pursuing this research, every ACL I saw, I spent up to 90 minutes with, talking to them about what rehabilitation alone looked like. And then I'd talk about surgery, and then I'd talk about this idea of putting the knee into flexion. And it was very harrowing for me and the patients, to be honest, and their families, because we're all going into the unknown. And they only went into it, probably all the ACLs I saw, only 10 or 15% would do it, because the others would say, look, thanks for your time, but I'm going to get surgery. I didn't blame them. But in that first 100 patients, incredibly pioneering to do this new treatment, which, to be frank, when you talk about it with most surgeons and clinicians, doctors, physios, sports science, etc., they say, well, this is stark raving crazy, putting an acutely injured knee into flexion. with all the risks of stiffness, DVT, etc., or the risk that it doesn't work. So the patients were equally brave, courageous, bold, pioneering. And in that first 100, we had some spectacular successes and equally spectacular failures. And we only found out if it failed at the end of the 12 weeks when we did the MRI and examined the knee. None of the patients regretted doing it. They all wanted to try it as their first preference, knowing that they could always get surgery. And patient 38 came along, Oliver, who was also a very good rugby player. And he did it because, unfortunately, he had a jaundiced view of surgery through his family. And he didn't do well. And I remember the meeting with him and his mum and dad. He was only 16 at the time. And it was as all bad things happened late, the last appointment on a Friday evening. And it didn't work. I felt his knee and my heart sank, that there wasn't a good restoration of his anatomy. It was a very ordinary Lockman pivot shift. Looked at the MRI and there was an ACL OS score of 2, thinned, elongated, non-anatomic outcome. And I obviously crossed him over to surgery. And I went home that night and, quite distraught. All weekend, I looked at the MRI and I looked at Oliver's initial and then was follow-up. And then I looked at the ones that work of the first 38. And I remember patient 17, 18, 19 didn't work. And we got lucky the first 16 times, which is extraordinary because the chances of it working back then was like 1 in 3. So we got dialed or tossed a coin and got it right 16 times in a row. And I saw a pattern, and the pattern was there was displaced tissue outside the notch. I saw the ACL tissue sitting down. Invariably goes under the lateral femoral condyle. As the femur rotates violently, ACL gets broken and the synovial membrane is breached and some of the tibial stumps thrown under the lateral femoral condyle. So that was sort of an epiphany. And I know talking to the radiologist, in particular, Rowan Sabra, who's the lead radiologist, and Rowan agreed. And then, but over the last 6 years since, we've had epiphany after epiphany of looking at the acute MRI and then seeing how it behaves to either rehab alone or bracing 30 to 90 or doing one of the CBP prescriptions. And then we started measuring the gap distance in the rupture zone. We started seeing what percentage of ACL tissue was breached or thrown out of position or displaced, where the epicenter of the ACL injury had occurred. Was it proximal, middle, distal? Did it involve the attachments, femoral or tibial? How much the degree of detensioning from its normal alignment? And then we started measuring the bone bruise and the size of it on the lateral femoral condyle. And that was a marker of how far the knee had subluxed or dislocated, how much hemarthrosis there was. So these other markers of the violence that had befallen the knee and disrupted the ACL anatomy. And was that anatomy healable? So it all comes down with closely interrogating the pattern of injury of the ACL, just like you would the pattern of a bony fracture or any injury. For most of my career, it didn't matter if the ACL was ruptured. It's ruptured, and that's end of story. ACLs don't heal. So there's such a thing as a partial tear, and everyone recognised those since MRIs have been around since the 90s. But there's a range of ruptures from a healable rupture to don't even think about it because it's got such a huge gap distance. There's so much displaced. So think of it like a fracture. There's a spectrum from normal bone to a comminuted intra-articular fracture. We need surgeons to put that bony fracture together, and you'd be crazy to put a splint on that because you'll get a malunion, you'll get a stiff wrist if it's involving the wrist. Same with the ACL. There's a spectrum from normal anatomy to a partial tear to a larger partial tear, intrasubstance disruption where there's no visible gap distance. And then with enough force and violence or newtons of energy, the ACL will start to separate and you'll start to see gap distance or a rupture zone. And then more violence or more energy, the greater the separation in the rupture zone. And we're talking about skiing, it's how fast you're skiing, how high you're jumping and landing. So the skiers who do their ACL coming off the chairlift and they get caught up with the partner next to them, they don't have a bone bruise. It's a less injured ACL. There's usually no displacement. We hypothesize the synovial membrane's intact. Very different story to an Olympian going down the downhill 130 kilometers an hour. And she unfortunately catches an edge and there's so much energy. That's going to cause a lot of injury to the ACL and concomitant injuries with that ACL. So we started realizing not all ACLs are the same, just like not all other injuries are the same. There's a degree of muscle strain injury to the hamstring that could get better in a matter of weeks or could be, take 3 or 4 months. So it's about defining the ACL injury and giving it a tear type and then saying, well, let's triage you into either rehab alone, put a sleeve on, or you could brace 30 to 90, or you could do one of these CBP prescriptions. And but it's still a work in progress because we're still learning. We've learned a lot in 6 years.
Yeah, terrific. And one of the things that we want to dig into today is that you, as I understand, you're finding out that a higher percentage of skiing ACLs are of the lower grade tear types that are probably more amenable to healing through a bracing protocol. How did you sort of start to discover that, and did you want to talk a little bit about the different sports and how they tend to, what sort of ACL injury they tend to lend themselves to?
Yeah, so after sort of devoting myself to this research from 2020 onwards, I've seen a lot of ACLs, and I've probably seen 7,000. I haven't got a specific number, but I would have seen 7,000 either patients in the clinic or I've looked at their MRIs that people have asked me to classify. And I've worked very closely with you and Ryan, collaborating with, Elevate Physio in Jindabyne, with Ryan and the lovely colleagues there. And we've also collaborated with the clinics all over Japan, Bevan, Asia Physio. Unfortunately, the number one cause of ACL injury that I see in my practice is skiing. And I love skiing. I started skiing when I was 10 years old, but you could argue the human being wasn't meant to put a boot on and a ski. We're meant to walk and run. But it's a beautiful sport, but it does have a risk of catching an edge and that ski rotating and generating enough torque to unfortunately injure the lower limb, either a fracture or an ACL. That's why it's so important to have an excellent ski instructor and have good equipment, et cetera, et cetera. And Ryan, hopefully you could talk about mitigating the risk of these injuries sometime in this talk. But it goes skiing number one, and then the next sport is soccer, futsal, and then it's touch football, OzTag, netball, basketball, rugby league, rugby union, AFL, and the list goes on. But skiing's number one. So I've seen a lot of skiing ACLs, and then I started to see a pattern over the last 4 years where I always asked them how fast they were going or how high they were jumping. And the low velocity skiing ACLs, so they're a beginner and they're going 5 or 10 kilometers an hour and they unfortunately lose control and fall over, versus the advanced skier going down a black run really fast. You see a very different pattern of injury. So the low velocity, you have an isolated ACL injury with usually no concomitant injuries. There's no bone bruise, but they've got a ruptured ACL. and it's usually undisplaced. So there's no tissue out of the notch. It's within the synovial envelope. We hypothesize that because you can't really see the synovial envelope on the MRI. But if the ACL is blown up, sort of bulbous and fusiform, it's like it's bleeding inside. And patients always come up with great ideas. They said, Tom, it's like a sausage. I've got a sausage inside my notch, and the skin's intact, and the meat's injured, which is the ligament, and it's bleeding and it's blowing up. And you can see that on the MRI versus the patient who's an advanced skier going really fast, jumping really high. They usually have a displaced ACL with a larger gap distance, bone bruising, meniscal tears. So this pattern, just time and time again, you can see it. And I always ask the patients for a video. A lot of them have a video of their mechanism of injury. And you just try to imagine how much force went through that knee. Also, the MRI is a photograph of how much force went through the knee. So all the injuries that you're looking at on the MRI, if you just in your mind's eye say, well, how much force was enacted on this knee? And that's illustrated in the size of the hemarthrosis. Do they have a lipohemarthrosis? Are there fractures? Are there significant capsular injuries, meniscal injuries? And then what coexists with that is a very badly disrupted ACL, because the femur's subluxed a long way on that tibial. Once again, very different to the beginner getting off the chairlift who ruptures their ACL. And you can also diagnose it over the phone. If Ryan takes a call, or Bevan, you take a call, say, look, I was going 5 kilometers an hour, caught an edge and fell over, felt a pop, didn't really hurt. I tried to get up, my knee felt unstable. I actually skied on and it gave way again. And then I got down to the village and I could walk around the village and my knee didn't really swell much. You're dealing with a less injured ACL clinically, even before you've done the MRI. And the corollary of that is I was skiing really fast and I jumped and landed and it really hurt and I couldn't wait there. I had to get taken off the mountain. My knee feels very unstable. I've got a very swollen knee. That's a more injured ACL. We think the swelling is from the bleeding of the ACL. The membrane's been disrupted. That ACL's hosing blood into the knee. And there's other things bleeding, capsular injuries, bone bruise, subchondral fracture, capsular meniscal injuries. So you've just got to try and, in your mind's eye, ask the patient, what was the mechanism of injury? How much force was involved? And then those things, swelling, could you wait there? The other important thing to ask is, have you injured that knee before? So I always say, if I met you the day before you hurt your knee, have you ever injured your knee? Because about 5% of ACLs have happened weeks, months, or years before. And you're dealing with an acute on chronic injury, which is very different. And you shouldn't brace that, because it'd be crazy. It's often written on the MRI that it's acute on chronic, but you need to ask that question because that's very different pathology.
100%. You do find that I think there's a lot of people out there who've ruptured their ACL years before, but never ended up seeing anybody for it and have been living their life, possibly with an ACL, with a torn ACL inside their knee, because when you start questioning them, they'll say, I did do that thing 10 years ago when I was playing football, but wasn't, I never saw anyone for it, but my knee was feeling wobbly. So,
and they can have a spectrum of healing. So they're people who have not braced, maybe not seen a health professional, and it'll all depend. Their spontaneous healing will depend on what type of ACL they got in the beginning, and also whether they're a sedentary worker. Do they sit down all day with their knee bent? Are they in IT, sales, where they sit down? Are they a lawyer that's working on a big case? And I've had lots of these examples where people have spontaneously healed their ACLs, and so that they may have got a degree of spontaneous restoration or healing of their anatomy, ranging from no ACL deficiency, all the way up to a quite a high volume heel. So yeah, that's where it's so interesting. So you'd go back to clinically asking them, how did you get hurt the first time? How much force was involved? And then in those following 2 months after your ACL injury, were you sedentary and sitting down, like as an academic, you're studying for your HSC, or were you up on your feet, walking around as a tradesman or a physio or a nurse? All these things are important to analyse, I think.
I think uniquely in skiing as well, some of these ACL deficient knees can slide a little bit under the radar because a lot of recreational skiers that might ski at like an intermediate to advanced level with like decent technique, the sport of skiing itself isn't that demanding on the knee. Like everything, if you're turning from the hip joint and all that sort of thing, everything's kind of in line straight up and down as opposed to a field-based sport like footy or netball. So I think at that sort of intermediate to advanced level, you could quite easily, I can imagine, not realize that there's anything wrong with the stability of your knee.
Yeah, yeah. And it'd be interesting to hear your opinions on this, Ryan, as well, because I know in our clinics in the ski resorts in Japan, we see quite a lot of Asian people who are often don't come from a ski background. So we see a lot of adult beginner skiers, and they tend to be the types that are walking through our door every day. So those low speed injuries that you were talking about, Tom, where the ski doesn't release, which is often another tell. And those low force ACLs, we probably see 10, 15 of those for every one of the expert high speed skiers or people jumping, big jumps and whatnot. Partially because that's just tends to be who's skiing in Japan, but also I think when you're going a little bit faster, the ski will just pop off at a higher speed, and that sort of spares the ACL. And experts just don't tend to fall that much because they're very good at what they're doing. So, I
Yeah.
think those low speed ACLs are really, far outnumber the high speed, high impact tears. Would you find the same in Australia, Ryan, or
Yeah,
in Europe?
absolutely in Persian. I think there's actually it's a little bit researched to the mechanism of that beginner ACL injury, and they call it the phantom foot thing. And essentially, I'll try and describe this for our podcast listeners. I'll do my best. But if you've got a beginner in a snowplow and they lose their balance backwards and they fall over, so their hips drop below their knee, almost like they're sitting down in a big snowplow. So their skis are in a triangle, and one of the skis starts to pick up and turn them, and that becomes the downhill ski. The tail of the uphill ski can catch on the snow and start to rotate out. And because bindings don't have a release mechanism on the heel piece, well, most bindings don't, that will provide like a internal rotation of the tibia with an abduction force, and that's what usually ruptures it, but at a very slow speed, like you said, so it can be quite isolated. But yeah, I would agree, Bevan. I think, especially at our Perisher clinic, which is on the snow, we get a lot more of the walk-ins. Yeah, probably 10 to 1, somewhere in that ballpark of very unscientific analysis of the numbers.
Yeah, yeah. All
And
right.
often and I'm in this age group for sure, that older adult that's never skied who ruptures at low velocity, not casting judgments on any of them, but they tend to be lower demand in their other activities that they do the rest of the year. So they might have given up rugby, netball, soccer, and the only high demand ACL demanding sport they do is skiing once a year. And the rest of the year they go to the gym, they do Pilates and yoga, they walk, they run, they swim. So that's why the CBP is so alluring to them, so they've got a less injured ACL and they're not a very high demand ACL demanding athlete. So a lot of them say, after you've explained everything to them, they say, well, why wouldn't I try this as my first position? And if it doesn't work, I might continue with non-surgical treatment and see how I go. And if I'm unstable, then I'll definitely call up the surgeon. So that particular type of patient, there is utility in offering the CBP as their first position to manage the injury, provided they've got no other serious injuries in the knee that need a surgeon. And usually they don't, because they're low velocity.
100%. That's our bread and butter in Asia Physio is that patient profile. Somebody who's not that athletic, you're not doing much twisting, maybe, as you say, with respect, people that are a little bit more sedentary in their normal life and go on a ski holiday and unfortunately have one of those low speed tears. So
I probably should add, Bevan and Ryan, that most of the surgeons, if they're listening to this podcast, and in defence of the surgeons, because my father was a surgeon and a lot of my friends and colleagues are magnificent knee surgeons, they often don't offer surgery to that demographic we're talking about. The 50-year-old skier that ruptures his or her ACL. They might say, "Why don't you try rehab alone and see how you go? And I'm here if your knee's unstable in the months or years ahead." So what we're saying in our paradigm of thinking, wouldn't it be nice to have a higher or a better healing outcome of your ACL for the rest of your life? Because a lot of 45, 50-year-olds will live to 85, and it'd be nice to have an ACL plus do wonderful rehab and have dynamic stability of your knee with great rehab. But why not try to get some restoration of your ACL by putting a brace on for 6-8 weeks? So that's the thinking, that it's another non-surgical adjunct to managing the patient non-surgically is this bending the knee and try to get a better healing outcome for the patient.
I think
But a lot of the surgeons don't offer reconstruction surgery to that group we're talking about.
So if you're in that demographic, or if one of our listeners is in that demographic and maybe they've had an injury similar to what we've just been describing, what are the next steps for them then? I guess is the next question, isn't it?
Yeah. Well, maybe we did. Sorry, Tom. We did talk about splitting the episode up into two parts. So it's definitely the next area to dive into there, Ryan, which is what do people do once they've torn their ACL on their ski holiday, and that is a very complex topic as well. So we might get back to that in episode 2. We'll take a quick break and pause for this episode now, and return with the second half of this episode uploaded on the Knee Gurus, which should be uploaded in about a week from now. So thanks for listening to this episode of the Knee Gurus, and thanks to Tom and Ryan. We'll take a quick break there and we'll get back and continue this discussion after this short break. Thanks, guys.
Thanks, Bevan. Thanks, Ryan.
Thanks, Kevin.
Thanks for tuning in to the Knee Gurus, brought to you by Asia Physio. To learn more or explore online consultations, visit telephysio.com or asiaphysio.com. If you found today's discussion helpful, share it with someone who's exploring their knee recovery injury options too. Thank you, and bye for now.